I'd now like to welcome our next speaker, Dr. Ankoor Shah. Dr. Shah is Assistant Professor of Ophthalmology at Harvard Medical School and the Director of the Pediatric Ocular Trauma Service at Boston Children's Hospital. Dr. Shah has served as the Physician Advisor for the Virtual Care, Innovation, and Digital Health Accelerator Program at Children's Hospital. This program started in 2016 as the Virtual Visits Program. And for the past 4 years, Dr. Shah has piloted platforms, developed best practices, and streamlined patient workflows. With this unique experience, he is poised to discuss telemedicine, its past, its current applications, and future innovative efforts. We welcome you, Dr. Shah.
Thank you, Dr. Haidari, and thank you to the entire Alumni Meeting Committee. Dr. Gardner set up this talk very nicely, introducing the idea of virtual visits. And what I'd like to tell you about is what we see as the future as a community here at Harvard Ophthalmology. But I think to get to the future, we need to understand the evolution of virtual visits. And so in the pre-COVID phase, the innovative past, if you will, we were doing mostly office-based visits. And shown in this graph to the bottom is the percent of total visits on the y-axis and the weeks of the year on the x-axis. In blue are the virtual visits, and in gray are the office visits. And as you can imagine, prior to March 13th, when the national emergency was declared, we really did office-based care, and less than 1% of our care was virtual. With the COVID pandemic, we were forced to distance, but at the same time, we were forced to actually take care of our patients and make sure that health outcomes didn't suffer. And we ramped up our virtual care process, as Dr. Gardner just alluded to, and the virtual care really became a mainstay of treatment and healthcare delivery. The period beyond COVID-19 is for us all to put together and determine how this mix will help our patients going into the future. If we're going to use virtual visits, we are all evidence-based clinicians, and we need to know what the evidence is. And so if we go back to our past, in 2016, the Innovation and Digital Health Accelerator, as Dr. Haidari mentioned, started the virtual visit program. And the ophthalmology department at Boston Children's Hospital was one of its first partners. Through this program, we were able to conduct 360 virtual visits going up to March 13th. Now, this sounds really small in comparison to what we're doing now, but it was a way to innovate and find best practice. We started in the postoperative space and then moved to the return space as the insurance companies allowed. And you can see that most of those visits were really done with established patients. We were able to see on the pediatric side, strabismus, orbital and periorbital disease, and even ocular surface disease. And we asked if these visits might be useful by sending out a survey to providers and to patients at the point of care. We looked at provider-defined effectiveness of the virtual visit, and shown in the pie graph to the right, you can see that 91% were either very effective or somewhat effective in the blue. And patient satisfaction was about 9 out of 10 overall. So we deemed that virtual visits from these data were actually feasible. So come to March 13th, and a national emergency is declared. And March 16th, we have to take care of our patients and distance. So we flipped the switch. Virtual visits became dominant. 30+ providers across the department started doing these virtual visits. And 2,600+ virtual visits were conducted over the weeks ensuing. As shown on the bar graph to the right, in the blue are the virtual visits and the volume that was occurring each week from March 16th onward. We also adapted. We started talking to each other, talking across departments, and trying to come up with even more best practices and innovative ways to do a virtual examination. And we again did not forget that we need to measure effectiveness of this technique, and surveyed each of our providers and the patients. And again, about 94% graded these visits. 94% of the visits were graded very effective or somewhat effective. And patients were also satisfied. So what is the vision to the future? Well, like I said at the beginning, that's for all of us to decide. And so I wanted to go through a few different people. I started with Dr. Theodore Bovey, one of our newest members of the MD class of 2020. And he said that advances in virtual ophthalmic care will allow patients to receive the highest quality eye care, no matter their financial, geographic, or social barriers. Dr. Grayson Armstrong, our current director of the Eye Trauma Service, is interested in using virtual care to augment the power of clinical decision-making tools that we have out there, such as artificial intelligence, machine learning, and clinical decision-making tools to help bring this care to patients worldwide. Dr. John Miller, the director of our Retinal Imaging Center, was just featured in Dr. Gardner's talk and has talked about the eye care through a hybrid model. Dr. Paulo Silva from the Beetham Eye Institute wanted to emphasize that it is paramount that we establish standards to ensure patient safety and outcomes. And Dr. Torin, our Chief of Ophthalmology at BIDMC, said that it will be up to us to determine how best to incorporate virtual visits into our clinic flow. And so I leave you with this. In the past, pre-COVID, we were seeing patients in the office. As we came through this pandemic, we started adapting and using virtual care as needed. The future, I believe, is a combination of office visits, virtual visits, and hybrid visits. And I think it's for us to determine how this curve will look in the weeks to come. And I just wanted to thank everyone from across this department as we continue to innovate. It is all up to us to figure out how we can deliver healthcare better for the future.